Good morning, everyone. Welcome all of you joining the public presentation organized by the Occupational Health Center. Today's the topic is about long COVID, the rehabilitation and return to work considerations. Today, we are so pleased to have Kerry St. George. She's the physiotherapist of the Wellness Institute Clinic, and also coming with Shelley Sargent. She's the manager of the clinic services from the Wellness Institute. We would like to begin by acknowledge that we are on the Treaty 1 territory, the traditional territory of the Anishinaabe, Greek, OG Greek, Dakotas, and Diné people, and the homelands of Métis Nation. We respect the treaties that we were made on this territory, and we acknowledge that we are all treaty people. At the Occupational Health Center, we commit ourselves to our process of reconciliation with Indigenous communities. So for participating in this session, we appreciate that you could just put your questions in the chat box area and on the right side of your screen. The presenter will try to answer it afterwards, after the presentation. You can see that this event is already kind of being recorded. So we will going to share the recorded link to you review later and share on the social media. And please connect with us if we cannot answer and cover all the questions in the Q&A, because we have more than 200 people registered for this session. We may have lots of questions coming up depending on how the time left. So if we cannot answer all the questions, then we will try to send you the answer later on. For some folks, I started with some folks from Vancouver or the other provinces, not only in Manitoba, doesn't know anything about Occupational Health Center. We are now located on the 167 Sherbrooke Street, Winnipeg, Manitoba in Canada. Occupational Health Center is the community health center funded by the Winnipeg Regional Health Authority. We provide the services to the Manitoba workers with work-related health issues and work closely with the Joint Workplace Health and Safety Committee for training. And all our service is free. And please visit our website and for more information and resources. And now this is the time to join me to welcome Kerry and Shelley. I'm going to stop screening now.
Okay, hello everybody, welcome. I'm just going to share my screen here. Okay. Okay, so my name is Kerry. I'm a physiotherapist at the Wellness Institute in the Rehabilitation Clinic. Last year in the spring of 2021, our manager at the time was realizing that this emerging health condition was going to impact a lot of people. And so we were tasked with developing a program to help people with long COVID. I come from a musculoskeletal background, so I didn't really know anything about long COVID or its related diseases. So it was very much a learning curve that I'm still undergoing, and still, all the information is rapidly changing, and new information is coming out. So what we're going to go through is what is long COVID, and to help people understand the symptoms of long COVID, and what kind of rehabilitation we do for people with long COVID, and how to support people returning to work with long COVID. So post-viral conditions are nothing new. They've been seen in other pandemics, including the Spanish flu in 1919, after the SARS pandemic in 2003. And it continues ongoing with people who've developed West Nile. And it's similar to a condition called chronic fatigue syndrome, or myalgic encephalomyelitis. So people who are diagnosed with chronic fatigue syndrome, they have a substantial reduction or impairment in the ability to engage in pre-illness activity levels for 6 or more months. And the fatigue that they have is often very profound. It's new in onset, It's not a result of ongoing or unusual exertion and is not alleviated by rest. They also have conditions called post-exertional malaise, which I will go into in subsequent slides. They have unrefreshed sleep, and they can have cognitive impairment and or orthostatic intolerance. And so all of these things that are similar to chronic fatigue syndrome, they sound a lot like long COVID. And so a lot of the information that I give my patients is in the realm of chronic fatigue syndrome. So what is long COVID? In October of 2021, the World Health Organization defined post-COVID conditions as it occurs in individuals with a probable or confirmed history of COVID-19. Probable because a lot of times early on in the pandemic, people did not get a PCR test, and right now PCR tests are not common, they're home tests. It usually happens 3 months from onset of COVID, and can happen, and symptoms last for at least two months. And they cannot be explained by an alternative diagnosis. They have common symptoms, including fatigue, shortness of breath, cognitive dysfunction, as well as other symptoms, and generally have an impact on everyday functioning. Symptoms of new onset following the recovery of acute COVID-19 episodes, or persist from the initial illness. So it again can be new, or it can be ongoing from the initial illness, and it impacts everyday functioning, but it also fluctuates and relapses over time. So some people get a little bit better, and then they get a little bit worse, and then they get better, and they get worse. So that's very much what I see when I see my patients. So long COVID can happen in both people who are hospitalized and people who have not been hospitalized and have very mild illnesses. And again, they can be a continuation of the initial infection. And then after the initial infection, some people can recover, but days or weeks later start to develop symptoms. And anecdotally, from what I've seen, a lot of it is related, seems to be related to stress. And when I was researching this, this presentation, certainly some research has come out, and just recently from December and from November of this year, saying that stress and distress play an impact in increasing risk of people who have long COVID. So this one study found 32 to 46% increased risk of people who reported distress before they had caught COVID. And if you had 2 or more types of distress, your increased risk of 50%. So they call it distress was depression, anxiety, worried, perceived stress, loneliness, loss of loved ones, food insecurity, financial insecurity. And I've certainly seen that with a lot of my patients, that they seem to have stress before, right around, slightly after they had COVID, and that seems to perpetuate and their COVID symptoms and have risk of developing long COVID. And in this one study, they found a stronger association between long COVID and psychological distress than the known physical risk factors such as obesity, age, other chronic illnesses. So what are some of the symptoms? So some symptoms, brain fog, headache, fatigue, dizziness, shortness of breath, loss of taste and smell. People had gastrointestinal, stomach issues. They get heart palpitations, temperature deregulation. So there are lots of different types of symptoms, and not everybody has symptoms in the same fashion or in the same amount. And so it makes it a very tricky thing to try and treat because no two person is the same. So some recent Canadian data out of August 2021, they found that 72% of people said they had fatigue, tiredness, so loss of energy. 39% said they continue to have coughing, the shortness of breath, difficulties thinking or problem solving, and generalized weakness. And further from the same study from the Public Health Agency of Canada, roughly 15% of adults experience COVID symptoms for more than 3 months, which equates to about 4.6% of the Canadian population, which is approximately 1.4 million Canadians. Of those people, 47% have symptoms for a year or longer, and 21% of people, their symptoms are lifted often or always, and those are often the people that I see. And that equivalents about 300,000 Canadians, which is a significant amount of people who have long COVID symptoms. And 74% of people have missed work due to symptoms. So that's over 1 million people have missed work because of long COVID. So symptoms, fatigue. So fatigue is described as a profound loss of energy, that the battery is totally drained or flatlined. It's not the typical fatigue you get after exercise or a busy day where you kind of sleep it off and you feel better the next day. Sleep does not make it better. And I often give the analogy of a cell phone battery. You know, a person without long COVID, they have brand new cell phone battery, their energy bank is nice and big. But a person who has long COVID, they have the old cell phone, the one that doesn't stay charged very well and only has so much, has limited charge. So they have only 50% of their battery to use. And so it impacts them significantly on how much they can do. And fatigue is often made worse by physical activity, mental or cognitive activities, social situations, and stress. So part of the fatigue that people get is they can develop a condition called post-exertional malaise. So post-exertion, so after you exert, you become sick. So it's defined as the inability to recover normally following physical and cognitive or emotional exertion, resulting in fatigue that's more profound, more devastating, and longer lasting than observed in patients with other fatiguing disorders. And unfortunately, it's not proportioned to the activity that they do. So normally when, pre-COVID, somebody might exercise, they feel fatigued, but it's normal, it's proportioned to what they do. Now somebody might just go for a walk for a block and then be in bed for several days afterwards, or have, go out with friends and then be in bed for several days afterwards and feeling sick and having a flare-up of their symptoms. I often give the analogy of energy dollars. A person, again, they have so many dollars to spend in a day. Pre-COVID, they might have $100, but these people only have $50 to spend. And if they spend $60, they go into the hole by 10. And just like the bank, you get charged overdraft fee as a post-exertional malaise fee of $20. You're in the hole by 30, and then you sleep and rest, but you only get $50 back. So you only have $20 to spend the next day. And then again, if you go into this pattern of overdoing your energy, spending more energy than you have, you go further and further into the hole. And that's what I see with a lot of these patients when they come to see me, is they do more than what energy than they have, and then they crash afterwards, and then it takes longer to recover from. So post-exertional malaise can come from various different things. Physical activity. So again, it's overdoing the energy that you have. So it can happen from simple things as doing the laundry. It can happen from cooking. It can happen from exercising or taking a walk, and even showering. Showering is often a very hard thing for patients to do, that they have a shower and then it takes them several hours to recover after having a shower. And I think it's more heat related but it's the standing. It can happen from cognitive activities. Paperwork, reading. I've had many patients say, they go to read a book, they get one paragraph in and then they can't remember what they were reading before. It can happen from driving. I've had patients tell me, you know, they go to do an errand, or they're going to pick up their kids, and then they're driving and they can't remember where they're going. It can happen from medical appointments. So having appointments and medical appointments, insurance appointments, bank appointments, anything like that, where they're having to concentrate a lot, that can be enough to set them over the edge and cause this post-exertional malaise, this sickness. Talking on the phone, you know, doing paperwork, loud in busy environments can also cause, with cognitive activities, to be overdo their energy. Social activities and stress and emotion also can cause post-exertional malaise. And so it's, you know, being in a busy environment, being in a loud environment where there's lots of conversations going on, meetings at work, when you're stressed out, those things can all cause people to go into post-exertional malaise, overdo their energy. So it's worsening of symptoms after exertion. It can happen immediately, but often with post-exertional malaise, it happens afterwards. So they might appear fine when they go into their appointment, or when they go in and talk, you know, have a social situation with a friend, or go for a little bit of a walk. Like, okay, that went well, but then 24 to 72 hours after you exert yourself, that's when you experience your symptoms. So it makes it really hard to tell where things, where you're at, because it's afterwards. And so, you know, you go into a medical appointment, the person thinks, oh, you look good, you know, you walked in well, you know, things are going well, but then they don't realize that it might take 2 or 3 days that you're in bed, that you recover afterwards. And it can take days, weeks, and if you do it enough, it can take months. And so it makes it hard to predict and manage. So brain fog. So brain fog is a, excuse me, a cognitive dysfunction. Is slow or fuzzy thinking that can lead to difficulties tolerating loud noises. That's a big thing for patients. Busy environments, concentration, attention, word finding difficulties, headaches, controlling motions. Multitasking is often very hard for people who have brain fog. It's just their brain can't process the multitudes of information that is coming in, yeah, their brain just becomes overwhelmed and overstimulated, and it causes people to become symptomatic, get that fuzzy feeling. So different factors contribute to brain fog. So when somebody is more tired or in post-exertional malaise, their brain fog is often worse. It's, you know, neurological or brain challenges, mood changes, shortness of breath, and pain can all cause more brain fog. There has been some research out there talking about hypometabolism in the brain, in areas of concentration and attention, that may be a contributing factor to brain fog. But when people are, again, more fatigued, more symptomatic, their brain fog tends to be worse. When they're less fatigued and less symptomatic, their brain fog tends to be better or less. So orthostatic intolerances. So this orthostatic intolerances are a term to describe symptoms people get after sitting up or standing. They can feel lightheaded, dizzy, faint, sick. This is often people when they get the tachycardia, the rapid heartbeat. Their blood pressure can go up or go really down, and so it's an inability to tolerate upright positions. And so it's standing, but it's also sitting. These people are sitting with feet on the floor. I recently saw a lecture about, they were talking about chronic fatigue syndrome, and talking about how much people were upright. And in people who, in the healthy controls, people were upright between like 14 and 17 hours a day. But in people who were chronic fatigue, they were upright out of bed between 0 and 7 hours a day or 8 hours a day. So it's the tolerance to upright positions that people struggle with. And part of the orthostatic intolerance is the deregulation of the autonomic nervous system. And I see this with a lot of patients. Our autonomic nervous system is our nervous system that we don't have any control over. It controls things that we can't control. So heart rate, digestion, skin temperature, blood pressure, etc., as you can see on the system. And when you have two subsets of these systems, you have your sympathetic nervous system, your fight or flight system, and you have your parasympathetic nervous system, your rest and digest system. And under normal circumstances, you have a balance between the two. So as I say to my patients, you see a bear, you know, that fight or flight system activates your tense muscles, you get your heart rate increasing, but after the bear goes away, your other system counteracts that and relaxes things and decreases heart rate in that. And for people who seem to have long COVID, those systems are imbalanced, which can lead to that orthostatic intolerance. It can lead to the tachycardia. And so that's one of the things that I see in patients is this deregulation between the two systems. So another symptom, sleep disturbances. So some people have difficulties falling asleep. Some people have difficulties staying asleep. And they say to me that they wake up in the middle of the night and it just feels like they're wired, or their heart is just pounding in their chest. And sometimes people, it's just they sleep all the time. So they sleep for long periods, day and night. And all of them, and when they wake up and their sleep feels unrefreshed. They don't feel like they got any rest. And so sleep disturbances are common, and then that again leads to more fatigue, and more fatigue leads to more brain fog. So it becomes a vicious cycle. So exercise or activity intolerance. I've seen a lot of patients have told me they've gone to, they've talked to friends or they've talked to healthcare providers, and then they're like, oh, it's just deconditioning. And it's really not deconditioning. They're not struggling with their symptoms because they are deconditioned. A lot of these people were really fit and active before. And yes, they might be a bit deconditioned, but it's not solely deconditioned. And symptoms can worsen after they do exercise. So at the start of our long COVID programming in 2021, we started collecting patient data as part of a College of Rehab student project. And in this past summer, Shelley, our manager of clinical services, did a statistical analysis on some of the data. And this analysis demonstrated significant levels of dysfunction in performance-based tests during the initial intake assessment. So the 6-minute walk test was used to assess aerobic capacity and endurance. The distance covered in 6 minutes is the primary outcome of the test. Our long COVID cohort walked a mean distance of 356 meters with a standard deviation of 142. The mean perceived exertion was 3.9, and the rate of perceived dyspnea the mean rate of perceived dyspnea was 1.4. So comparing our samples to normative data, the normative data in the literature, we can see that our patients' mean values fall below the normative values for community dwelling elderly people aged 80 to 89. But our mean age cohort was 41. So that is a significant reduction in their ability to walk. In the 30-second sit-to-stand test, the 36 sit-to-stand test is a test to develop of leg strength and endurance in older adults. In this performance test, one attempts to complete as many stands as possible from sitting in 30 seconds. Our population's mean score was 10.9, and a rating perceived exertion was 4.8, and the dyspnea was 4.2. So comparing our data to the published normative data in the literature, our patient's mean score was comparable to an 85 to 89-year-old active community dwelling male and females. So again, they had significantly reduced capacity to perform the activity. This slide I got from the Long COVID Physio Forum that was in September. And I thought it was really telling about exercise intolerance. And this was in chronic fatigue syndrome, again, similar to long COVID. And they compared to healthy controls. And so they looked at the feeling of reported symptoms of fatigue, lightheadedness, muscle, joint pain, cognitive dysfunction, headaches, nausea, weakness, insomnia, and sore throat and swollen glands. So in controls, immediately after the testing, this is for cardiopulmonary testing. Of course, they had fatigue, they had muscular joint pain, those kind of things. And then they next day, and then they looked at immediately following. And then they repeated it again on people who had chronic fatigue syndrome. And the differences between people with chronic fatigue syndrome is they had significantly more symptoms after testing, and then the symptoms lasted longer. And people who had in healthy controls, they didn't have a sore throat, they didn't have insomnia, they didn't have any cognitive dysfunction, they didn't have any lightheadedness. But in people who chronic fatigue, they had those symptoms after they did exercise. So again, it's not always how they do on that day, it's after the fact. So more recently, they looked at with people again with that post-exertional symptom exacerbation or post-exertional malaise. They found that people had decreased volume of oxygen consumed at peak exertion and at ventilatory aerobic capacity. So they decreased oxygen consumption after the second cardiopulmonary testing. Sorry, back up. This was from, they did 2-day cardiopulmonary testing on people with long COVID, and they did without with healthy controls. Workload. So it was decreased at peak exertion and at ventilatory anaerobic threshold after on the second test 24 hours after the first. Their heart rate was decreased at peak exertion and ventilatory capacity, again 24 hours after the first test. And they had decreased volume of air clearance per minute at peak exertion and at peak anaerobic threshold, again 24 hours afterwards. So in deconditioned people, they find that that people, when they do a 2-day cardiopulmonary testing, that they maintain their values from test 1 to test 2, even if they're deconditioned. But people who have this post-exertional symptom exacerbation or post-exertional malaise, they cannot repeat their performance from one test to the next. So there is something else going on rather than deconditioning. So research summary. So on our in our research, we found again the mean distance traveled between the 6-minute walk test falls within, at 41 or mean 41 years, but they fall between 80 and 89, which is significantly reduced function, as well as the mean number of reps completed in the 30-second test was similar to those between the ages of 85 and 94. So again, significantly reduced ability to function. So mental health is often a big symptom of in patients. It is known to worsen, long COVID is known to worsen pre-existing health and mental health conditions. It often, if you had depression or anxiety before, it often can make it worse in preceding your COVID diagnosis, as well as due to profound and debilitating consequences of long COVID, mental health can suffer. And just recently in the Journal of Neurological Sciences, November 2020, and this was in hospitalized people, but life stressors contributed substantially to worse functional cognitive and neuropsychiatric outcomes 12 months after hospitalization. Stressors include financial insecurity, food insecurity, death of a close contact, or new disability. So mental health is a major factor in long COVID patients, and it needs to be addressed when you're looking at long COVID patients. So possible mechanisms of long COVID. They're still doing research. There's stuff coming, every day, every month. There's new information coming out about what is causing the underlying long COVID. So some hypotheses include like inflammatory or autoimmune processes, autonomic nervous system dysfunction, organ damage, mitochondrial injury, which is mitochondria is the energy production of this part of the cell. And so if you're not producing as much energy, of course, you're going to be more fatigued. Persistent clotting. I read a study and they are looking at with long COVID patients, and a lot of them, majority of them have microclotting in. Endothelial damage, persistent viral protein in the body. So those are some hypotheses. Ongoing research is being done on this, but no definitive aha has come out, and so it makes it harder to find, with treatment strategies when you don't really know the underlying mechanism of what causes long COVID. So diagnosis. Unfortunately, because we don't know the underlying mechanism of long COVID, it makes it really hard to have a medical test to diagnose long COVID. So diagnosis is typically done clinically based on symptoms. So it's listening to the patient's symptoms and history. And there was one research study that they talked about in this long COVID physio forum, that there is excellent classification of long COVID or not long COVID based on symptoms. And so when people talk about their symptoms, it's very easy to, it's very clear that, and based on some research blood data, that people either have long COVID or not long COVID. So blood tests, research on blood tests are still ongoing. They have found in blood tests that there is significantly elevated proportion of activated T cells in people with long COVID. There's more likely to show recent activation of the herpes virus, such as Epstein-Barr virus. And Epstein-Barr virus is a known contributor to chronic fatigue syndrome. And there's significantly reduced morning cortisol levels in people's bloods. But there's no like definitive, look for this in blood tests yet. That research is ongoing. So it makes it really hard for insurance companies or, to doctors and everything to have a definitive diagnose. Yes, this is long COVID based on a medical. We have to go based on person's symptoms and history. So rehabilitation. So rehabilitation, because there's still so much unknown, and we don't have a cure for long COVID yet. We don't have the do this and you'll get better. My role in rehabilitation as a physiotherapist is to help optimize people's function. and to help people, support people as they adjust to the effects of long COVID, of this chronic health condition. It's to help people understand symptoms and triggers and what makes them worse and what makes them, what they can do to help manage their symptoms, and develop strategies to help people manage their symptoms. And validating and believing patients. I have, in initial assessments, many times, patients says, you know what, you are the first person who actually understands. You are the first person who actually knows what you're talking about, because they're often not believed, and validating and believing patients is very much part of people's rehabilitation. And we know that multidisciplinary teams, because this is a complex chronic medical condition, we know that even just physio or just counseling or just occupational therapy or just medication, we have to work as a team to help these people. Treatment has to be individualized, and it has to be based on their symptoms and triggers. So when I see and when I assess a patient, I'm asking what their symptoms are. We're going through what their activity levels are like, what their perceived triggers are. And so we have to base our recommendations and our treatment based on patient symptoms. And because no two patients are alike, treatment is different for each patient. And there's sometimes where a patient comes in and I think, okay, this is what I'm going to do with them today, and they come in with something else in left field, and I have to pivot and have to work on those kind of things as they come in. So it's a very individualized treatment. It is a lot of counseling. It's a lot of education. In my other part of the job with musculoskeletal injuries, exercise and all those kind of things are part of it. Exercise isn't a huge part of this, especially at the beginning, because exercise often makes them worse. And so it's a lot of education, a lot of me talking to them, helping them understand things. So the big thing is when people do experience post-exertional malaise or have post-exertional malaise, graded exercise treatment is not indicated. The World Health Organization has come out with this. The CDC has come out with this, that graded exercise testing and treatment actually makes people worse, and it is contraindicated. So if people flare up their symptoms after they do an activity, exercise is not the answer for them. And again, treatment is not a one size fits all. You often have to have multiple different treatments to help. They had this analogy, and I really like this analogy. When people have multiple health conditions and this complex illness going on, they often have a lot of anchors weighing them down. Now, this individual has one anchor, but say these people have 3 or 4 anchors weighing them down. And if you try one treatment, you pick up one anchor, but they still have 3 or 4 down. And so you have to start doing multiple things. So you have to, okay, we're going to try some physio, let's try some medication, let's try this, let's get you into counseling. You have to start picking up all the anchors at once. Because if you only pick up one anchor at a time, that person will never go, because there's always 3. And then if you go, okay, well, let's try this, that didn't work, and you throw the anchor back, and let's try this, and you throw the anchor back, well, they're still always going to have 3 or 4 and never get anywhere. So you have to try multiple things. You have to do multiple different treatments to help these people. So rehabilitation. So again, strategies, again, based on individual treatment. We talk a lot about stop, rest, and pace. So stopping, they have to listen to their body. Pushing through is not the answer. Pushing through won't get them better. It will actually make them worse. So getting people just to understand they got to listen to their body. If they're feeling tired, they got to rest. If they're starting to become symptomatic, they have to stop. Rest. Dedicated rest time in the day helps people. Thinking about that energy battery that I talked about. when people rest in the day, that's like plugging in that cell phone. You get a little bit of extra battery power to help and pacing their activities so that they're not doing all their activities at once and then not being able to do anything for the rest of the day. So it's a balance between activity and rest. We do a lot of activity modifications. So changing the way how people do things. Like, I get people to sit down when they cook or cut vegetables. We get people, showers, they have to, sit on a chair, things like that for activity modification. We do lots of stuff based on planning and prioritizing what is important, what is not important, what can be delegated, asking for help, those kind of things. Stress management is key, again, because there is strong association between stress and long COVID. Stress management is a key factor for patients. So we do deep breathing, relaxation, doing meditation, those kind of things with patients. Mental health supports. So again, we want people to help people deal with any underlying mental health issues, support for doing illness adjustment, and just supporting a person to help with their mental health. And then cognitive rehab, again, to help develop strategies to help compensate for symptoms. So a lot of these things, again, is symptom management rather than a cure, but we don't know what that cure is, and is that cure in 3 weeks, is it 3 months or 3 years? And we have to help these people, whatever that time frame is between now and when the medical community comes up with an answer for long COVID. So I'm a physiotherapist, so I don't have much into pharmacology at all, because it's not my area of expertise. But there is some research in chronic fatigue and going in trials for long COVID, talking about low dose naltrexone. That is a medication to help for people with alcohol and opioid addiction. And it's at 50, I believe it's 50 milligrams is for alcohol and opioid addiction at a low dose. So they're saying like 4.5 milligrams that it can help with long COVID symptoms. Ongoing research is out there. I have given information to patients to pass along to their doctor to talk to them about that. So that is one medication. So they talk about antihistamines as well, but ongoing trials are being to look at medications. So return to work, because this is a complex health condition. It fluctuates. It's multifactorial. We want, for return to work, we want to have a person to have a sustainable level with minimal flare-ups. Doesn't mean they're going to be symptom-free, but they're not crashing, after they do an activity, that they're in bed for several hours or several days, because that's just not sustainable. We also want to balance the ability to work and to live your life. People can go back to work, but if all they do is work, they are absolutely dead tired when they get home, and all they can do is go to bed and sleep. They can't engage in their life. They can't do anything outside of work. We have to look at that, because we also want people to live their lives as well. It's a slow progression on a graduated to return to work plan. I mean, really slow, not weeks, it's months. Because again, we have to go based on a person's symptoms if we want to push them forward, but we don't want to push them too much that they become symptomatic and it's unsustainable. So it takes significantly longer, months, not weeks. So what we do for return to work with our clients is, when we start to consider returning to work, I want to add some work simulating tasks at home to check for tolerance. So I just recently had a patient, thinking of returning to work in the next month or two. It's like, okay, look at financial reports online, go and have a Zoom conversation with friends to check tolerance for being able to do meetings, read emails, write reports, do word processing. If you do a physical job, do physical tasks and see if you can tolerate, because if you do these things and then you become symptomatic, then you may not be ready to return to work yet. We want people to be able to do at least, 2 to 3 hours of work with some short breaks to be able to go back to work. And we usually when we start people, we usually try to do it non-consecutive days, so like a Monday, Wednesday, Friday, or a Tuesday, Thursday, to start people, to allow them to have breaks in between. So return to work is a lot about modification. So if you're an employer, is there a way to offer like home or hybrid working where they work from home for a little bit? Because commuting time, driving can be as much of a flare of their symptoms. So reducing commuting time, flexible working hours. If they're more, fresh in the morning, you maybe get them in the morning. If they're more fresh in the afternoon, maybe you get them starting their hours in the afternoon. So being creative and flexible when exploring work tasks and roles that the person can perform. Making tasks less physically, mentally, or cognitively demanding, reducing interruptions. Interruptions are a big thing for people with long COVID. When they get interrupted, they lose their train of thought and they often have difficulties getting back to it. So accommodations, some examples of accommodations. So changing the start and finish time, pacing breaks throughout the day and away from the workplace. I often say at lunch, go sit in your car for 10 or 15 minutes, close your eyes, do some of your breathing, that kind of thing. Having quiet space from noise and interruptions to rest is important. Alternating days, shorter days, days off. Having time off for healthcare appointments. This long COVID physio term this is illness work. So when they have all these medical appointments, that is work for them as well. So it's illness work. So that they don't have to kind of do it in off hours. So provision of equipment to help with like ergonomic chairs, assisted technology, parking spaces close to the building so they don't have to walk, elevators, that kind of thing. Strategies to help with special difficulties. So memory aids, noise canceling earphones. If you have a busy office and noise is a problem for them, you get people with noise canceling earphones, and that might drown in enough noise that they can do their job. Reducing workload. So, doing fewer tasks, doing one task at a time, multitasking, multitasking is a big problem for a lot of people. So, doing one task to completion at a time is better, or doing more time for usual tasks or tasks that don't require a short deadline. There might be temporary changes to a role or duties. And then working alongside colleagues for tasks to help people through. So those are all examples of how people can be accommodated. So treatment options. So of course, we have our clinic post-COVID rehab program. So they get a physiotherapy assessment. And then after that, then we make recommendations on, whether they need to see counseling or they need cognitive rehab, dietitian, that kind of thing. Because we are a fee-for-service clinic, it limits how many people that can see us due to funding and their ability to pay. And often even though people, need to see the counseling or need to see the occupational therapist, because I'm the most accessible and it relatively costs the least to see me, that often I'm doing, some cognitive rehab, doing some counseling, doing things that are kind of outside of my traditional physiotherapy role as well. There are a long COVID self-management group online. through the WRHA. It runs a couple times a year. I know the next session is going to be in the winter and an evening session. Our social worker actually does one of the segments on that one, so that is another one. Easy Street at Misericordia Hospital is another place where they're doing some COVID rehab as well. And then, you know, with family doctors, referrals to cardiologists if they're having chest pain or heart palpitations. You know, if people have POTS, which is an orthostatic intolerance, to see a special cardiologist for that. Rheumatologists, internal medicine specialists, immunologists. You know, it has to be a whole group thing. And here are some resources that I have used that had the Long COVID Physio is an excellent website. Their resources. I will pass this along to Tiffany, and then she can send this out. They have lots of good information in it. Shared Health has some information, and at the very bottom there is a return to work recommendation document that is from Realize Canada, which just came out at the beginning of the month. So that is everything I have. It's you know, there's a lot of information that with long COVID, and this is kind of only the tip of the iceberg, but hopefully that gives you some better understanding of what is long COVID. Thank you.
Thank you so much, Kerry. We appreciate that your information was really informative. You passed in lots of material about what the symptoms, the rehabilitation, and then return to work consideration. Yeah, we now learning this is a long process, not talking about weeks, it's talking about months, right? So yeah, so many people saying thank you for your great presentation. I have already copy and paste some of the questions on the document. So would you mind to check us over? That we really appreciate. Yeah.
So the referral program. So for the Wellness Institute, it can be self-referred, it can be referred through insurance companies or doctors. They don't need a referral to come in and see us. They just have to let us know it's about long COVID, because we do longer booking times for that. And then we make recommendations for that as well. Like our services are covered under like Blue Cross or Great West Life, those kind of things. You know, if people have access to some long-term disability, if they're on long-term disability, there might be some access through, you know, getting people to getting insurance companies to help with some of the costs of these programs as well. So yeah. What about people with long COVID that work at an HCP in acute or long-term? How do return to work look like? So with like nursing and healthcare aides, we often start them, you know, they might start back, especially at the beginning, just catching up on things, getting them back into the workplace, buddying them up with people, doing reduced hours or reduced number of patient volumes. With nurses, we've done like, okay, you're seeing one, you know, you're doing, you know, if your normal caseload is six patients, you may be doing 2 or 3 to start with. It really depends on the person and you know, the managers and what can be done. We try to do non-consecutive days and reduced hours to start with. Where can someone start if they feel like they have long COVID? Family doctor? Do they have to rule out other health issues first? Certainly we want to rule out other health conditions, especially if you're having heart, you know, issues with your heart or, you know, lung issues, that kind of thing. So certainly you can talk to your family doctor about that. But you don't have to rule everything out. You can certainly start doing, you know, coming in and seeing us or seeing another provider to start understanding, to start going through some of the stuff on the pacing, the planning, the resting, those kind of things to start with, because we have to manage symptoms. And, if it's other health conditions, great. But if it's not, a lot of these people, the testing comes back normal. Again, we want to be able to help people, manage until that day when they find something to help with these, or I'm going to say cure these people. Has there been an opportunity to review the findings and with places like WCB or employers? We haven't necessarily had the opportunity to review some of these findings. A lot of information is coming out, but we are more than willing to if WCB or insurance providers reach out. So it just says, have you seen any post-COVID mobility issues? My friend got COVID in May and August started having mobility issues, not being able to walk or stand since, progressively got worse. It's hard to say. It could be that maybe they're in a very bad post-exertional malaise flare, that the fatigue, and so that, some people we know with chronic fatigue syndrome are actually bedridden. And so that can be it. It can be a pain issue. It's hard to say without an assessment, but, people with long COVID can have mobility issues. So can you expand on cognitive rehab and what it looks like? So cognitive rehab, our occupational therapist does majority of the cognitive rehab. We do have the ability, provided people can pay for or have funding for, a program called Brain FX, which is a program that can pinpoint different areas of cognition that people are struggling with, and then they give exercises and stuff to help with people with those cognition problems. So that's one part of, can be one part of it. But often, if people have problems with memory or attention, a lot of it is making lists, writing things down, keeping a calendar, planning out your day, those kind of things to help kind of people keep on track of things, making a list of what you want to do that day or that week, those kind of things. But it really depends on what part of the cognition people are struggling with the most. Sometimes our OT will have worksheets. If they have word finding difficulties, they'll do some word finding exercises. So it varies with that. Are you aware of any other wellness centers that are offering assistance with long COVID rehab? In Manitoba, again, there's an online program that runs. I'm not sure of, I'm actually not sure of who else does it. Again, Easy Street is another one that does it. There's no, I know in the UK and the US, they have a lot of these long COVID programs within their healthcare facility that is really multidisciplinary with the medical team, physio, OT, counseling, various different doctors of different specialties that do. Unfortunately, Manitoba has not gone that way, which is really unfortunate because that's what people need. So I don't know where else in Winnipeg people are offering stuff. So early in the presentation, there was a correlation between long COVID and pre-existing mental health components. Is there a focus on addressing pre-existing condition? Certainly, if they get into counseling, they can certainly start to address those pre-existing conditions. That's a bit out of my scope, especially that mental health piece of it. And so I think certainly I've done lots of recommending to see our social worker who does their counseling part of it. There's some people have access to an employee assistance plan or those kind of things. So certainly we do need to address it. In our program, unfortunately, it's because we are a fee for service. It sometimes doesn't always get addressed by the correct people because of that barrier. So. Okay, so any thoughts of having a speech language pathologist involved with those word finding difficulties, other language difficulties, or do you direct people to speech language services? We direct people to speech language services if they need it. We don't have a speech language pathologist within our clinic, so we would redirect them. The word finding difficulties, it's more of a cognition than a what's the right word? Yeah, so our OT generally does the word finding difficulties parts of it. Other languages, I mean, that's certainly a barrier. But we refer out because we don't actually have an SLP within our facility. Would you be available to do a Teams education session for staff in the long-term care facility? Yes, certainly. You can reach out to our manager, and we can certainly do more of these sessions for people to help understand and what's going on. So what are the range of long COVID impacts? For example, is there a mild long COVID or extreme long COVID? And what would mild long COVID look like? Yeah, so there is a range of things. So if some people can be very mildly effective, they're able to do all their normal activities, but maybe they're just a little bit tired. Or, when they get a little bit tired, that's when their cognition starts to go a little bit, but they're still functioning, able to do things. I had one patient, and anecdotally, I wasn't seeing her for long COVID, but anecdotally, she was talking about, when she exercised really hard, she started to feel a little bit, but then it was gone, and she was able to do light exercises. So certainly those are more mild cases. I'm seeing the extreme long COVID, the ones that are severely affected, because they are the ones that are not able to work or not able to function very well in their day-to-day life. So those are the ones that I'm seeing. I'm not seeing necessarily the mild ones, because often those people, I'm going to generalize this a little bit. If it's only affecting you a little bit, you're a little bit less likely to seek out medical attention to it, because you can kind of work around it, or you're like, okay, I can't do this. No, it's not a big deal. Whereas people who have that extreme long COVID, or are often or very affected by it, those are the ones that we are seeing, and probably the ones that we hear about the most, because they have the most disability. I think that was the end of the questions. So I think, yeah, that was the end of the questions.
Sorry, Kerry, I got one more question.
Okay.
Are you being asked to provide the return to work assessment and documentation to WCB and insurance provider to substantiate people being off work?
Yes, we have been doing return to work assessments, documentations, return to work recommendations for people with WCB, insurance, that kind of thing. Yes, we have been. Yes.
Thank you so much, Kerry, and all of you to staying, with us and bringing out all those good questions. We appreciate Kerry and Shelley bringing and sharing all the really, really informative information to us. So yeah, okay. You can see that this session is already recorded. The slide and the record link will be sent to you to your email what you register at. So hope everyone have a safe and peaceful holiday. Happy holiday to all of you. So I won't see you next year until January. Thank you, Kerry, again. Thank you, Shelley, and everyone for your participation. So take care, everyone. Bye-bye.
Bye.